Hello and welcome back to the Deep Microbiology channel. In today's episode, we continue our journey with part 2 of the Stool General Analysis series. We'll be taking a closer look, both with the naked eye and under the microscope, as we explore the macroscopic and microscopic examination of stool samples. From color and consistency to cells and parasites, there's a lot to uncover. Let's dive in. Now let's look at how we prepare a stool examination report. The general form should begin with basic patient information including the patient's name, age, which is important for distinguishing between babies and adults, and gender. The stool examination report is typically divided into two main sections: macroscopic and microscopic examination. Macroscopic examination involves the visual inspection of the stool sample with the naked eye. In this part of the report, we assess several important features, including the color of the stool, which may indicate bleeding, bile obstruction, or dietary factors. We also evaluate the consistency, whether the stool is formed, semi-formed, watery, or mucoid. The presence of mucus and visible blood is noted, as these can suggest infection, inflammation, or gastrointestinal bleeding. Additionally, any parasites visible to the naked eye, such as adult worms. The second part of the report is the microscopic examination, where the sample is examined under a microscope to detect cells, ovocysts, and other microscopic elements as you see here, and we will discuss it in detail later. Let's start with the macroscopic examination of stool in babies, focusing on what is considered normal and what is abnormal in this age group. Baby poop comes in different colors, and these can change based on what the baby eats. A newborn's first poop is called meconium, is the thick, sticky, greenish-black substance that forms in a baby's intestines before birth. It's made when the baby swallows amniotic fluid inside the womb. As this fluid travels through the baby's gut, most of the water is absorbed, leaving behind this tar-like waste. Most babies pass meconium within 48 hours after birth. This is a good sign that their digestive system is working properly. Sometimes, babies can pass meconium before birth into the amniotic fluid. This can be harmless, but if a baby inhales meconium-stained fluid before or during delivery, it can cause a serious condition called meconium aspiration syndrome. This happens when the sticky meconium gets into the lungs, making it hard for the baby to breathe, where it leads to a rapid breathing or grunting, and bluish skin color, which is called cyanosis. After the baby starts feeding, the color of their poop changes to a greenish shade. Then by around the third or fourth day, it usually turns yellow. For breastfed babies, it's often mustard yellow and may appear a bit seedy, while formula-fed babies tend to have yellowish or tan-colored poop. So seeing green first, then yellow, is completely normal. It just means the baby's digestion is developing as it should. Brown stool is considered a normal and healthy color, especially in babies who have started eating solid foods. Now, let's look at abnormal colors that may indicate a need for medical attention. Pale white or gray color. This may indicate liver problems or a blockage in the bile ducts, most commonly due to biliary atresia. Black color. If a baby has black-colored stool after the first week of life, and it is no longer meconium, it may indicate upper gastrointestinal bleeding, which is abnormal and can present as melena, black, tarry stool. However, before drawing this conclusion, it is essential to take a thorough medical and feeding history. This helps determine whether the black stool is due to a benign cause, such as iron-fortified formula or swallowed maternal blood, both of which can darken stool without indicating any pathology. Accurate history taking is crucial to differentiate these harmless causes from potentially serious gastrointestinal conditions. Bright red blood. Seeing blood in a baby's diaper can have different causes depending on timing and source. In newborn girls, a few specks of blood within the first week of life may be a false period, caused by withdrawal of maternal estrogen, which briefly stimulates the baby's uterus to shed its lining. A completely normal, harmless phenomenon that resolves within days. However, bright red blood in the stool, in both boys and girls, could result from minor issues like constipation, anal fissures, nappy rash, or swallowed maternal blood, especially if breastfeeding with cracked nipples. More rarely, it can indicate cow's milk protein allergy, infection, or underlying gastrointestinal conditions such as Meckel's diverticulum or necrotizing enterocolitis in premature babies. In contrast, the macroscopic examination of stool color in adults is generally similar to that in infants, with only a few notable differences. One key distinction lies in the interpretation of yellow-colored stool. In adults, yellow stool is typically considered abnormal, as it may signal underlying conditions such as pancreatic disorders, celiac disease, cystic fibrosis, or Giardia infection. However, yellow stool can also be benign, especially when it is transient and linked to dietary factors, such as a high-fat meal or rapid intestinal transit. Conversely, yellow stool in newborns, particularly those who are breastfed, is often considered normal and part of typical early digestion. Another significant difference involves the presence of black stool. In adults, black stool often signals gastrointestinal bleeding, or may result from the ingestion of substances like iron supplements or bismuth-containing medications. In newborns, however, black stool, known as meconium, is completely normal during the first few days of life. After the meconium phase, if an infant consumes iron-fortified formula, their stool may appear dark green to black, which is typically harmless and should not be mistaken for pathological bleeding. However, if black stool persists without an identifiable cause, especially beyond the neonatal period, it may warrant medical evaluation to rule out underlying issues. Stool consistency. Stool consistency is classified using the Bristol stool chart, which is designed to categorize stools into 7 types, ranging from type 1, the hardest, to type 7, the softest. As seen below, the chart provides a clear visual and descriptive guide to help assess bowel health and function. Type 1 and Type 2. These stool types often indicate constipation. If you frequently experience these, it may suggest that your diet lacks adequate fiber and fluids, leading to difficulty passing stools. Type 3 and Type 4. Formed poop, which may resemble corn on the cob or sausage, is ideal and should be easy to pass. It indicates a healthy and well-balanced diet. Consider normal. Type 5, Type 6, and Type 7 are softer and looser stool types associated with diarrhea. They may indicate a gastrointestinal infection, food intolerance, or an inflammatory bowel condition. Stool consistency in babies. A baby's stool consistency can vary depending on whether they are breastfed or formula-fed. Breastfed babies typically have stools that are loose, thin, and grainy, often resembling cottage cheese or grainy mustard. This texture is normal, though it can sometimes be mistaken for diarrhea due to its runny appearance. Formula-fed babies, on the other hand, usually have more formed stools. While still soft and mushy, their stools are generally firmer than those of breastfed babies. However, if your baby's stool becomes unusually watery or more liquid than usual, it may be a sign of diarrhea. If your child has several watery stools in a row, it's important to contact your pediatrician, as babies are at higher risk of dehydration. Mucus and stool. It's normal to see some clear mucus in stool, but in trace amount. In general, mucus in your stool happens when something affects mucosa in your intestines, which are part of your gastrointestinal (GI) tract. There are some common, harmless reasons you might see mucus in your stool, such as 1. Dehydration. If you're not drinking enough water, your body pulls more fluid from your colon, making your poop hard and dry. To help move it along, your gut produces more mucus to lubricate the passage. 2. Stress. Believe it or not, your gut is super sensitive to stress. When you're anxious or under pressure, your brain can mess with how your intestines move, and that can lead to extra mucus being released. 3. Dietary changes. Sudden changes in what you eat, like adding a lot of fiber, eating spicy foods, or eating something your body doesn't tolerate well, like lactose, can irritate your gut a bit. That irritation may cause it to produce a little mucus as a protective response. Serious causes such as 1. Infections. Whether it's bacterial, viral, or even from parasites. These often come with diarrhea, cramping, or fever. 2. IBS, irritable bowel syndrome, is a common condition that affects how your gut functions. It doesn't cause damage to the intestines, but it can lead to mucus in your stool. 3. IBD, inflammatory bowel disease, includes Crohn's disease and ulcerative colitis. Causes mucosal damage, ulcers, and frequent mucus with or without blood. Blood in stool. The presence of blood in the stool can result from mild conditions like hemorrhoids or indicate serious diseases such as rectal cancer, can cause occult, hidden, or visible bleeding, usually accompanied by weight loss, fatigue, or changes in bowel habits. Polyps, non-cancerous growths in the colon or rectum. Some may bleed or turn into cancer over time. Also, Crohn's disease, proctitis, cirrhosis, and stomach ulcer. Stool pH. In adults, the normal stool pH typically ranges from 7 to 7.5, which is neutral to slightly alkaline. In breastfed infants, stool pH is usually the lowest, 5 to 5.8, due to active fermentation of human milk oligosaccharides, HMOs, by beneficial bacteria such as bifidobacteria. In contrast, formula-fed infants often have a higher stool pH 6 to 7, closer to neutral, because their gut microbiota is different and less efficient at fermenting carbohydrates compared to that of breastfed infants. Now let's apply everything we've learned in macroscopic examination practically. As you can see here in sample 1, this stool sample shows visible mucus, which appears as an off-white to yellowish material. The stool itself is brown in color, and we will assume the consistency is formed. Mucus is present in large quantity, appearing off-white to yellowish color, and can therefore be marked as 3 crosses, and there is no visible blood present. And no visible parasites are observed in this sample. So when you see a significant amount of mucus like this, 3 crosses, it may suggest irritation or inflammation of the intestinal mucosa. In this sample, the stool is off-white in color and has a mucoid consistency because it's mostly made up of mucus rather than solid matter. The mucus is present in a very large amount. We'd mark that as 4 crosses in reporting. There's also a small amount of blood visible, which would be recorded as 1 cross. This combination may indicate significant irritation or inflammation of the intestines, possibly due to an infection or an underlying inflammatory condition. In sample 3, the stool appears brown in color but is heavily stained with visible blood, giving it a reddish and patchy appearance. There's no visible mucus, so we would mark mucus as nil. Let us assume the consistency is firm to hard. Due to the significant amount of visible blood, we would mark it as 3 crosses. This degree of bleeding could suggest active bleeding from sources such as severe hemorrhoids, anal fissures, inflammatory bowel disease, or possibly more serious gastrointestinal lesions. In the last case, the stool sample appears yellowish-brown in color. The surface's shininess suggests the presence of dispersed mucus in yellow color. The mucus appears to cover much of the sample and would likely be marked as 4 crosses. The consistency may be described as semi-mucoid. Parasitic worms are present, confirming the presence of a parasitic infection. No visible signs of blood are observed. After completing the macroscopic examination, we proceed to the microscopic analysis by preparing a wet mount of the stool specimen, which allows us to observe cells, parasites, and other microscopic components. The wet mount has been prepared, and the slide is now being examined under the microscope. At this stage, we can observe both pus cells and red blood cells. The pus cells appear round with a granular texture, while the red blood cells are also round but smooth and non-granular. Normally, fewer than 5 pus cells are seen per high-power field. A higher count may indicate inflammation or infection in the gastrointestinal tract. The presence of red blood cells is not considered normal, and usually suggests mucosal damage or bleeding. In this particular field, the number of pus cells exceeds 5, and red blood cells are also present, indicating an abnormal finding. One of the most commonly observed parasites in stool is Entamoeba histolytica, which causes amoebiasis. Another amoeba, Entamoeba coli, is frequently seen as well, but it is considered non-pathogenic. The cyst of Entamoeba histolytica typically contains 4 nuclei, although these nuclei are not easily visible in wet preparations. To enhance visibility, iodine staining is commonly used, which helps outline the nuclei more clearly. In contrast, the cyst of Entamoeba coli usually contains 8 nuclei, a key feature that helps differentiate it from Entamoeba histolytica. These are trophozoites observed ingesting red blood cells, a characteristic feature that is diagnostic of pathogenic Entamoeba histolytica and helps distinguish it from non-pathogenic species such as Entamoeba coli. The variation in trophozoite size reflects normal morphological diversity, likely influenced by phagocytic activity, and the dynamic extension of pseudopodia during motility. Here we observe that Giardia lamblia and Chilomastix mesnali trophozoites are both commonly found in stool samples and may appear somewhat similar under the microscope. However, they can be differentiated by their motility, which serves as a key diagnostic feature. Giardia lamblia trophozoites exhibit falling leaf motility, a fluttering, tumbling movement that resembles a leaf floating gently down in water. This type of motility is considered diagnostic for Giardia. In contrast, Chilomastix mesnali trophozoites move with a stiff rotary, spiral, motion, which helps to distinguish them from Giardia. Additionally, Chilomastix mesnali is a non-pathogenic flagellate, often described as a commensal organism residing in the human gastrointestinal tract. And here we also observe the Giardia lamblia cyst, which represents the infective stage of the parasite. The cyst is oval-shaped, contains 4 nuclei when mature, and may show axonemes and median bodies. It is highly resistant to environmental conditions, and is responsible for transmission via the fecal-oral route, typically through contaminated water or food. We can also observe Blastocystis species, it colonizing the intestines of humans and animals. The vacuolar or central body form is the predominant form found in human stool specimens, which varies in size and typically consist of a central body, or vacuole, surrounded by a thin rim of cytoplasm containing up to 6 nuclei. Other morphological forms such as amoeboid and granular forms have also been noted in stool samples, though their biological significance and developmental roles are still not fully understood. Here are various parasitic ova, larvae, and a ciliate parasite that are commonly observed in stool samples. Balantidium coli, a ciliate parasite. Hymenelepis nana, whose eggs are small and oval with polar filaments. Hookworm eggs, typically oval with a thin shell and clear space around the developing embryo. Ovophthenia species, which have a thick, radially striated shell. Schistosoma mansoni eggs, recognized by their characteristic lateral spine near the posterior end. Trichuris trichura, whose eggs are barrel-shaped with bipolar plugs. Strongyloides stercoralis larvae, identified by their short buccal cavity and prominent genital primordium. And Ascaris larvae. This is a different form of Ascaris lumbricoides ova that we can sometimes see in stool samples. If you look closely, you'll actually notice the embryo moving inside the egg. That movement shows it's developing into a larva. Other notable stool findings include Charcolidin crystals. These crystals are formed from the breakdown of eosinophils and are commonly seen in parasitic infections or allergic reactions. Fat droplets or globules. Normal in infants under 1 year old. In older children and adults, the presence of trace amounts of fat in stool may be considered normal, but increased amounts suggest problems with fat digestion or absorption. Possible causes: pancreatic insufficiency, liver or gallbladder dysfunction, Malabsorption conditions like celiac disease or giardia infection. Starch granules. Normally fully digested and not seen in healthy stool. Presence may indicate amylase enzyme deficiency, rapid intestinal transit, indigestion or malabsorption. Graded under the microscope as 1 cross considered normal, more than 1 cross considered abnormal. Yeast. Normally present in small amounts. Can multiply excessively in cases of gut dysbiosis, especially after antibiotics or corticosteroids. Pollen spores. Frequently seen in stool. May be confused with helminth eggs under a microscope. Fungal spores. Can be mistaken for entamoeba cysts due to similar appearance. Plant hairs in stool. May resemble larvae of hookworm or Strongyloides stercoralis under the microscope. Key distinguishing features. Often broken at one end. Have a refractal, shiny central core. And lack internal structures such as the esophagus and genital primordium, which are characteristic of true helminth larvae. Undigested food particles. Muscle fibers. May indicate incomplete digestion of meat proteins. Seen in conditions with low stomach acid or enzyme deficiency. Vegetable cells. Usually harmless. However, excessive presence suggests poor digestion or rapid transit of food. Plant spiral cells. Common and usually not significant unless in large quantities. Now let us finalize what we have learned in this case. The laboratory received a stool sample from a 24-year-old adult male patient. The sample was watery in consistency and red to brown in color, with an alkaline pH. If we look closely here, a portion of mucus appears, and we can grade it as 2 crosses. And blood is also present, graded as 4 crosses. No parasites were seen. A wet mount was prepared for microscopic examination. Under the microscope, after observing multiple fields, numerous pus cells and red blood cells were noted. As we can see here, no other findings were detected. In numerous fields, RBCs were counted as more than 40 per high-power field, and the pus cells were too numerous to count, as shown here in this field. Generally, there is no universal guideline that defines cells over 25 as uncountable. It depends on the laboratory's own standards. But in this case, the result is clearly abnormal due to the presence of a large number of RBCs and more than 5 pus cells per field, which is significant. The presence of numerous pus cells and red blood cells suggests inflammatory diarrhea, most likely of bacterial etiology such as Shigella, Escherichia coli, or Salmonella, which are common causes of bacillary dysentery. Thanks for watching. If you enjoyed the content, don't forget to subscribe to Deep Microbiology channel and turn on notifications to stay updated.